a few topics, and our faculty for today is Dr. Rajam Iyer. So, as you know, she is a pulmonologist as well as a palliative care physician working at Bhartiya and Pedi Hospital in Mumbai. And she uh, has uh, she, uh, she has tried to integrate palliative care in the pulmonology, and she continuously encourages the other pulmonologists uh, to come into the field of palliative care, to integrate palliative care into pulmonology. So this her journey has been so far successful, and with her help, we have been able to train some 50 or more pulmonologists in palliative care. Uh, so uh, she has won Har Gobind uh, Ghana Award, and um, she is an active member of many organizations, and she has been published many articles. So, with this introduction, I welcome Dr. Rajam Iyer and handing over you the session.
Thank you, Sunil. Thank you for the introduction. As always, Pallium is very kind to me. But it's nice to know that there are people who want to continue to learn more about how one could apply the principles of palliative care in other specialities. And that is very nice to know that, Pallium especially is continuing to increase the enthusiasm of people who want to learn. So today's topic is going to be a little different. Warning, it is a bit vast topic. It can be a bit, well, I don't want to call it boring, but it can be a bit intense. And a lot of it, it might sound very matter of fact to me because this is what I do daily, but it might not be for you. So please stop me then and there and let's clarify the doubts, because if you keep carrying it in your mind, then it's not going to serve its purpose. And it's meant to be a learning session for you and for me. So it's best that you stop me right there so that I can also clarify the doubts, understand your issues, and therefore learn from you what situations and circumstances you all work in. So today they've told me to talk about COPD, ILD, NIV, oxygen, which is really very, very vast. So let me start, because I know all of you are here after a day's work and it is the beginning of the week. So it has to be not boring and it has to be interesting, which you can make it by making it interactive. So let me start by asking you all a question as to where do you all see yourself after this course, as in your practice, to get such patients also? How do you think this particular topic will help you? You all can keep sending the chats. And the reason I'm asking you is, A, what do you all expect out of this talk? And I hope I'm at least try to meet your expectations somewhere in the middle, because I have made this topic for the first time, because I've taken palliative care COPD, palliative care ILD, and broken it down. This is one big chunk, and therefore it can be quite intense. So to start with, why is it important to talk about respiratory diseases? Because in the world over, we have a lot of patients suffering with respiratory diseases. So if you see India, you can see how 1 in 6, 1 in every 3, 1 in every 3 is an Indian. So the global burden, 1/3 nearly, is in this country. And also you must therefore remember that it is across socioeconomic status. So right from domestic fuel to bidi, to cigarette, to cigar, to pipe, to outdoor air pollution, to wages, to chemical exposures, and of course the recent pandemic. So you please need to realize that the global burden of illnesses is really, really high in this country. Thank you, Sairu, for replying COPD patients, the community at homes, help them in primary care setup. It would be helpful to treat patients with respiratory problems, cancer patients and patients with end stage. Okay, fine. So let me see if I satisfy your needs. So going ahead, this burden, which includes all the chronic respiratory diseases, asthma, COPD, ILD, occupation related, is a lot in this country. So we really do deal with a lot of patients across, I mean, the world's burden, a lot of it, 1/3 is in the country. And you are all very aware of this trajectory of the way people die. What we need to focus is the graph C, which is the trajectory in chronic organ failure, which includes respiratory, cardiac, renal, liver, everything. So if you see this graph, this is typically how a patient of ours with COPD or even interstitial lung disease fits in, where he's diagnosed fairly early, because there are some interstitial lung diseases that have a lifespan of 2.5 to 4 years, but there are some slowly progressive ones which live up to 10 to 15 years also, including COPD. Thank you, Satyanarayana Raju. So COPD, etc., we typically diagnose these patients at 60, 65, and they live for a long period of time, right up to maybe even 80, 85. So it's important to focus on these patients, because we as pulmonologists honestly end up seeing only patients in acute exacerbations. What happens to them once they go home is something we completely forget. And that's when palliative care teams, home care teams, family physicians, etc., can do a great job to make and improve the quality of life of these patients. Because again, it might be a slide that you have seen before from me only, that a chronic illness is like equal to falling off a skyscraper. The way you fall is directly proportional to the way you land, which means that as the patient is falling off the chronic disease skyscraper, if the patient and the caregivers were given unhurried, timely, sensitive conversations, explained about the disease trajectory, explained about what is going to happen, because you and me as physicians have seen more COPD, more ILD than the patient and the family. So the onus on parting with information about the illness trajectory is totally the doctors to foresee and foretell what may happen. And therefore, it gives enough time to the patient and the caregivers to process, analyze, cry over it, fight over it, and then decide how they would like to be treated in an emergency. All of you will agree to me that the best time to learn to swim is in a sea which is calm and not in a storm. So when the patient is in an emergency, it is probably the worst time to talk about, do you want to go to ICU? Do you want to be intubated? Do you want to have dialysis? Should I put a central line? That should not be the time. Imagine, I'm sure the age group of people I see on this group, you must have looked after a loved one who is sick. It is extremely distressing, even for doctors. When you look after your parent, grandparent, uncle, aunt, imagine the non-medicos. They'll say, doctor, do what you want. But that's not the right way to deal with it. We cannot be taking decisions for our patients. So it's very, very important to actually sit and talk to patients, and also identify those patients who are rapidly deteriorating. All the more reason that you need to call them and address this situation, because you will face an emergency, right? So the most important symptom that we face as pulmonologists is breathlessness, right? So important to know is the various ways of types of breathlessness and how do we measure breathlessness. So you have an acute breathlessness, which is obviously not in the purview of palliative care because the patient is breathless for the first time. You have to investigate. It could be airway, it could be MI, it could be embolism, it could be anything, and it could be a reversible situation. Then you have an acute and chronic, where a patient of, say, known COPD or a known ILD comes with an exacerbation, that is sudden worsening of breathlessness. And then, of course, you have chronic breathlessness. The different scales of measurement for the heart is a New York Heart Association. You all know that. For the lungs, it's the Modified Medical Research Council. And there's also another assessment called the BOG scale. And the BOG scale is actually a more practical assessment, which we do when we make the patient walk 6 minutes. Now everybody knows about 6 minutes. after the COVID pandemic, when patients walk for 6 minutes, and then we record how breathless is the patient. So you need to have assessment for your symptom so that you know whether your intervention is actually making a difference. Also, you can impress upon the patient itself that you were able to 1, 2, 3, 4, and now you're able to 1, 2, 3, 4. So impress upon the patient also how well he has become with the interventions. So types of breathlessness and assessment. Second thing about breathlessness is how do you evaluate breathlessness? It is a very abstract feeling, right? Now, pain is something probably all of us have felt at some point. Dental pain, labor pain, post-op pain. So we know of fracture pain. Breathlessness is something you have never, not all of us have experienced. Thank God for it. Patients, so therefore, when the patient says that he has an uncomfortable awareness of one's own breathing, that is the definition of breathlessness. So you have to believe. It's like how they say, it is when the patient says it is pain, that is pain. Pain is when the patient says there is. So breathlessness is also something that you and me probably haven't experienced, or all the doctors haven't experienced when they see the patient. So very, very important to take the history, of course, and the clinical examination. Now in respiratory system, it is very interesting because if you examine the patient ideally on a stool, if the patient is able to sit, ideally to examine a respiratory case on a stool so that you can go around the patient, see the front and the back. Because where is the maximum amount of the lung? Is it anteriorly or posteriorly?
Posteriorly.
Correct. It is posteriorly because the heart is sitting in the front. So very often we forget that. So you need to go back. And how do you do that? Best is to make the patient sit on a stool so that you can go around the patient. Second thing, very interesting way I learned examination of respiratory system is to first see the level of the shoulders. The side that moves less is the affected side. That is a dictum in respiratory medicine. Okay. So you see the patient sitting, the side that is moving less with respiration is the affected side. Next thing, you see the shoulder. If the shoulder is on the same level, fine. You know the right side is moving less, right is the affected side. What are the conditions you will think if the right shoulder is drooping and moving less? Yes, anybody?
Fibrosis or atelectasis or fibrosis on that right side.
So since right side is moving less, it is the affected side. When it is low in volume, something is eaten the lung. So fibrosis or collapse. Correct?
Yep.
Suppose the shoulder is elevated, right side, and it is moving less. Then what is it?
Some pneumothorax or pleural effusion.
Something filling the lung. And something filling the lung large to push the shoulder and the mediastinum to the opposite side. So massive pleural effusion and massive pneumothorax. Emphysema will not have a unilateral lung elevation. That will be the same side. No? Why should emphysema affect only one lung? So it's unlikely. So this is correct. Okay, so inspection itself will give you the differential diagnosis. So it's very important to inspect a bare chest. Extremely important. The next thing is, after inspection, is palpation, which is a time-consuming activity to do tactile vocal fremitus. It's okay if you can't do it. But when you do percussion, tactile vocal fremitus and percussion, you get a lot of differences. For example, if there's a pneumothorax, there'll be a hyperresonant note. If there's a pleural effusion, there'll be a dull note. That itself can give you the thing that, okay, when I put my stethoscope, I'm going to hear either decreased breath sounds or it will be, pleural effusion. So it will also be a decreased breath sound with a level of atelectasis on top. So importance of inspection, palpation is very, very evident. Now, when you come to conditions like, so this helps you in clinical examination. Once you examine the patient, the detailed history examination, then you obviously do the X-ray, etc. These investigations are not important. Some investigations get missed out. Those are pulmonary function test, arterial blood gas. Because everybody orders CT and everybody orders X-ray, everybody orders blood. Blood gas is important, the evaluation of any chronic breathlessness. 2 is the lung function test. And 3 is 2D echo. Why is 2D echo important for evaluation of breathlessness?
To rule out the cardiac
It will
cause.
give us clue about right heart condition.
Very good. So basically, breathlessness is not caused only by the lung. It can be the heart. What else can it be?
Pulmonary hypertension. No?
So it's not just the lung, it is the heart.
Low hemoglobin.
Hypertension comes in respiratory, vascular, mediastinal, airway, interstitial, air, all this comes in pulmonary. What else causes breathlessness? What happens tomorrow if you, Dr. Punita, decide to run 21 kilometers in the marathon? Will you be breathless?
Yeah.
Why? What is a condition called? You're deconditioned.
Metabolism increased, ma'am.
No, you're not prepared. Your body is not prepared for that high level of exercise. So what do people do for marathon? They train their body. The existing lung function, the existing muscular thing, they train to run 1 kilometer, 5 kilometer, 10 kilometer, 20 kilometer. So you get there, right? So your body is not conditioned to do a marathon. You are fine. You're a fit human being. Heart is fine, lung is fine, muscles are all in place, everything is fine. But still you get out of breath and you're not trained to run a marathon. So this is the third condition that causes people to get breathless is decondition. What happens with our elders? They'd hardly walk. They sit in one place. So if you don't use the muscles, you lose the muscles. So then even if they walk 5 steps, they're panting because they've never walked so much in their life. So this is also a very important cause. So this also needs to be evaluated by history taking and other ways of evaluation. Okay. So 2D echo is important. Coming to the arterial blood gas. What does ABG show you? What are the parameters in the blood gas? I know the slide.
pH,
Yes.
pH, PaO2, partial pressure of CO2, bicarbonate, base excess, base deficit, and serum values, electrolyte values.
Yeah. And most important, which
Lac-
we keep checking in the pulse oximeter.
Saturated.
SpO2,
Yeah. So partial, you have to know the saturation of the oxygen.
saturation of the oxygen.
When we talk of type 1 respiratory failure, we talk of patients who are hypoxemic, which means the partial pressure of the arterial oxygen is low. Okay. So what is low? According to the oxygen dissociation curve that all of you know, up to 60 also the saturation remains up to 90. It's after 60 there's a drop in the saturation, correct? So type 1 respiratory failure is only low oxygen. Carbon dioxide is normal, pH therefore is normal, saturation may or may not be low. Okay, so that is type 1. Now, can you tell me examples? That's the reason purposely I didn't put it on the slide of type 1 respiratory failure. You must have seen so many by now in clinical practice.
COVID, ARDS.
Anemia.
So what are those things? They affect which part of the lung? So if you talk of respiratory diseases, you should think in your mind clearly. Airway, vascular, parenchymal, and mediastinal conditions. So which will a hilar lymph node cause type 1 respiratory failure?
Parenchymal, ma'am.
So parenchymal.
Yeah.
Okay. So all the parenchymal conditions like a consolidation, like even acute pneumonia, right? It can cause type 1 respiratory failure. Interstitial lung disease, right? What about pulmonary embolism?
Yeah.
What about acute exacerbation of asthma, COPD? So airway, vascular, interstitial, those cause type 1 respiratory failure, largely. When we describe as type 2 respiratory failure, what is the parameter that is different?
CO2, PCO2,
So there is retention of COP,
retention of
carbon
CO2.
dioxide, And therefore, what happens? pH becomes,
Acidic.
Acidic.
so it's called, therefore, diagnosis is?
Type 2 respiratory failure, respiratory acidosis.
Yes, excellent. So type 2 respiratory failure with respiratory acidosis. So you have again two types. When a patient can come in acute respiratory acidosis, or there are some conditions like chronic bronchitis where the patient is forever in type 2 respiratory failure, but compensated. So when the pH is in the normal range, the patient is a compensated type 2 respiratory failure where the bicarb has got adjusted, the pH has got adjusted. When the patient is in acute respiratory acidosis, the pH obviously is not in the range of 7.34 to 7.45. Is that clear? That's all you really need to know. Now you tell me, what do you think are the causes of the type 2 respiratory failure?
COPD.
Okay. Especially chronic bronchitis. Pure emphysema or majority emphysema will be type 1. Chronic bronchitis is type 2. Yes. 2.
Restrictive lung diseases, chest wall diseases.
So broadly, therefore, type 1 respiratory failure is lung failure. Type 2 respiratory failure is pump failure. So the brain is not sending impulses. And even if the brain is sending, the neuromuscular is not acting. So a lot of the connection from the brain to the lung when it's affected. So like neuromuscular conditions, myasthenia, Duchenne's, MNDs, those are the conditions which will give rise to type 2 respiratory failure. Understood? Any thoughts, any queries, any suggestions? So if you understand when you see an ABG, type 1, type 2, automatically you look for causes, lung failure, pump failure. Okay? So that is important, and you must get an ABG done for all patients who report with breathlessness. Very, very important, gives you a lot of information. Next comes the lung function test. How many of you order it? How many of you can interpret it? I'm not going to be able to tell you how to interpret it, but I'm just going to give you certain tips of how I remembered it in my first year of MD. Okay. So first of all, the simplest form is spirometry. Okay. And the flow volume loop, if you remember how your PFT reports look. Okay. So please remember what you do in a lung function. You ask the patient to take a deep breath. So he is at total lung capacity. Okay. Then you ask the patient to blow out with maximum effort and possibility. So the patient blows from total lung capacity. He blows out to what we call as his forced vital capacity. What is remaining in his lungs is the residual volume. Right? Okay. Now, when you have airway diseases, the flow rates get affected because airway inspiration is active, expiration is passive. So if the airway is of a good caliber, the air flows in a particular speed. So you measure the flow rate. And how do you measure speed? When you say you're driving at 80, it is what by what? Speed of 80.
Miles per hour.
Or miles or kilometers, correct?
Kilometers per hour.
Kilometers or miles per hour. Similarly, flow rate in the air, in the lung will be what? Volume of air, ml per second. So flow rates is FeV1, forced expiratory volume in 1 second, or forced expiratory volume between 25 to 75 seconds. So please remember, flow rates are affected in airway disease. Asthma, COPD, bronchiectasis, bronchiolitis, etc. Small airway or large airways are affected. Therefore, FeV1 by FVC is the ratio we see for airway diseases. Okay. When you're talking of restrictive lung diseases, what has happened to the lung? It has?
Parenchyma become.
Lung has become?
Shrunk.
Lung has shrunk. So what happens? Volumes and capacity of the lung is reduced. So FVC, residual volume. So lung, in the airways, it is flow rates. in the parenchymal diseases, it is the volumes and capacities. So when you see a PFT report, you have to actually see only 3 values. First, look at FVC, then look at FEV1, and then look at the FEV1 by FVC ratio. If you do that, half your problem is solved. So only thing you need to remember is that forced vital capacity is patient dependent. So if you have a very good technician and if the patient has understood the procedure, he will do a great job. He will blow with all his might. But agar patient ko samajh mein, if patient can't understand or patient is unable to do, he will do. And your FVC therefore is patient dependent. But FEV1 is patient independent, right? I cannot say blow 2 ml in the first second of expiration. Come on, do. It is not possible. It is independent of your abilities. That is why we see the ratio, so that we know if X amount has gone in, 75% of the X should come out in the first second of expiration. So if the ratio remains well, you know it's not an airway disease. You got what I'm saying? So suppose you have blown out 4 liters or taken in 4 liters and blown out 3, it is 75%. That means airways are fine, it's doing its job. But if suppose in a patient like me, I've blown out only 2 liters, okay, and of that I bring out 75%, then because of my predicted is 70% less of what it should be, the 2 liters is not normal for my age, race, sex, and my physical condition. So the capacities become less. So you interpret it as probably a parenchymal or a restrictive lung disease. But please remember, never report a PFT without the history. Why? Because a patient of COPD can have pleural effusion. That will also restrict the lung. Correct? So you need to have an X-ray, you need to have the history, and you need to know why they are doing a lung function test. So please remember, when you're asked to interpret a lung function, please write, I want the history of the patient, or correlate clinically. Very, very important. You can't, it could be multiple combinations, right? You could have had a patient of, say, COPD who's had 1 lung or 1 lobe removed. It will also show restriction because that 1 lung is not there. Understood? Any thoughts, or should I wait for comments or queries?
Ma'am, about PEFR, ma'am.
Yes. So peak flow is a thermometer for asthma. Like you measure temperature, you measure blood sugar, you measure the peak flow in an asthmatic. Peak flow is best tool to monitor asthma, and that is a maximum amount of expiration in the first 10 seconds of expiration. So it's a forced blowout. Every patient has a different peak flow, and according to that, you train patients for managing their asthma. So you tell the patients to always carry peak flow, measure it morning, evening, and you say after 2-3 weeks of seeing the patient, you tell the patient, this is your best peak flow. Suppose the patient's best peak flow is 400 on an average. You give him a plan that suppose it falls to 300, you need to double the dose of your steroids. Suppose it falls to 50%, then you please need to reach a doctor. So peak flow is a great tool to see if your asthma is under control. 1, it's a great tool to follow up with your pulmonologist. Suppose you're traveling and you call up saying, I'm very breathless. I can ask my patient, what is your peak flow? Okay. What is your best peak flow? I know how serious the patient is. It is like a diabetic calling and saying, my sugar is 600, vis-a-vis my sugar is 60. You know how to react. So peak flow is a portable way to record the airway or how open your airway is. It's a great tool in asthma, not any other condition. Is that clear?
Yes, ma'am.
Yeah. So important for you to remember that. And then, of course, polysomnography is also part of PFT. And what is polysomnography? Can anybody say?
Sleep study.
Excellent. So it's for which condition?
OSA,
OSA or
Obstruction.
central or mixed. Okay, so it's also a part. And when will you order? When will you order a sleep study?
if patient is complaining of day somnolence,
So
daytime sleepiness,
first is in loud intermittent snoring.
Stop and score.
So that so much so that the family and the partner is disturbed.
mhm,
Awakening in the middle of the night with choking sensation. Poor quality sleep in the night. Waking up unrefreshed. Excessive daytime somnolence. Falling asleep in inappropriate places while talking, while driving, sitting in the meeting, waiting room. That's when you, and also most patients are probably obese, like what we call as a Pickwickian syndrome. Remember Charles Dickens' Pickwickian papers? That is called the Pickwickian syndrome. Okay. That is what is OSA. So this is just an overall of the lung function. Now coming to the specifics, there is a comment on the chat. Dr. Punita, would you want to say something? I thought it was Edmund's criteria, but I don't know this top bank criteria. What is it? Kindly educate. Dr. Punita?
This is most commonly used in the preoperative period to assess the high-risk patients.
Okay, what is it? I don't know. So kindly let me know.
S stands for snoring, T stands
Okay.
for trichomes. These are the acronyms. So it scores
Excellent.
on that.
Okay, fine. And
Yeah,
hypertension actually is, in fact, they say that young patients within the age group of 40 to 50, hypertension comes even before diagnosing sleep apnea because of the years of not sleeping. I mean, there's like a stress factor. So young hypertensives, you should investigate for sleep apnea also. So thank you for that. Okay, so coming to interstitium, what according to you is the interstitium of the lung? I'll first talk of ILD and then go to COPD. So where is the interstitium of the lung? This is anatomy, MBBS first.
between the alveoli and the blood vessel. The area between the alveoli and the blood vessel.
Capillary and the respiratory
Capillary is
bronchiole, right?
ma-
So the last apparatus, the alveolar, which takes part in respiration, respiratory bronchiole, and the blood capillary, pulmonary capillary.
capillary.
Therefore, you have these parts of the interstitium that we are familiar, we are taught, which is basically the intralobar interstitium, interlobar interstitium, subpleural interstitium. So where all the interstitium covers, okay, peribronchial, centrilobar. So these are all the parts because any of this interstitium can be affected or all of it can be affected. So just to show you that graph is this thing where you see the blood vessel and the oxygen. The sieve is the interstitium. Okay. Okay. So going ahead. When we talk of interstitium, basic problem with interstitial lung disease is majority of the cause is unknown. We don't know why patients get interstitium. There are many causes listed, which could be pigeon, which could be air conditioning, which is not maintained. It could be exposure to chemicals. It could be connective tissue diseases. It could be viral pneumonias like COVID was. So we really don't know. But the problem with this is that since this is a condition of unknown etiology, unfortunately, we don't know the treatment. So the treatment is mainly of symptoms, not of the etiology. And what we have noticed is some interstitial lung disease has this lifespan like cancer. It just progresses rapidly. So because the sieve of the lung is affected, the main function of the lung, which is diffusion, is affected. And therefore, patients come with chronic breathlessness, chronic cough, and desaturation on exercise. What happens to you and me when we exercise? To the blood pulse oximeter. If you and me exercise, what happens to the oxygen and the pulse rate and the BP?
Pulse rate
Oxygen
and BP
consumption
increases,
increases, pulse
no?
rate.
Say sorry.
Oxygen
pulse-
consumption increases, pulse rate increases, BP increases.
So pulse saturation will
May not
Remain
fall.
same, may not fall, huh?
Oxygen extraction might increase.
So what happens to the oxygen? What happens to the pulse ox when you exercise? When the heart rate increases, your respiratory rate also increases. So in normal people, oxygen saturation
Will
increases,
remain same.
increases or remain the same. Correct. Because pulse rate, BP, cardiac flow, cardiac output, respiratory rate, everything increases, oxygen also will increase. What happens to patients with interstitial lung disease? What did you see in COVID? What is happy hypoxia that we all saw in COVID?
Despite the saturation was low, they were not feeling breathless.
No. Happy hypoxics was they came in, walked in and desaturated.
Okay.
And they were absolutely fine and it dropped because it is affecting it caused interstitial pneumonia. So even in interstitial lung disease, one of the ways to catch interstitial lung disease is make the patient walk for 6 minutes, 6-minute walking test, which is a part of PFT. When they walk, their oxygen levels fall. And that means the diffusion is not taking place. And that's why they get scared to do even a little bit of exercise. So therefore, the needs of patients with interstitial lung disease is huge because they become dependent, they're constantly breathless, and the disease trajectory is very vague, it's very unpredictable. And that's the reason why very often non-cancer conditions do not seek palliative care. In cancer, what happens is there's enough research, robust research, to suggest 5-year survival rate, 10-year survival rate. You can't predict that about a COPD, a diabetic, a ischemic heart, or ILD. Because it is so unpredictable, patients don't want to, doctors don't want to refer these patients to palliative care. And patients also feel, I went to ICU once, I'm fine now, I can keep doing that all my life. So the point is it's not perceived as life-limiting and life-threatening. And therefore, we need to realize that this condition, interstitial lung, is a huge spectrum of conditions, which most of it, the etiology is not known. Therefore, there's no direct treatment for interstitial lung disease. It's only symptomatic treatment. And now antifibrotics like pirfenidone and nintedanib, which delay the fibrosis. So it slows the progression according to research. When it is in ground level, we really don't know how effective it is. So the needs arising from the symptoms are huge. Dependency, the fact that it's incurable, progressive, distressing symptoms, caregiver burden, no treatment available as such, and therefore how the end of life should be actually addressed. So you all know about this breathing, thinking, functioning model, which all our patients who are chronically breathless are affected. Is there somebody who can explain to me the breathing, thinking, functioning model so that I know I don't have to talk about it? Everybody is aware of it? Yes, no, maybe? Everybody.
You told us last time, ma'am, but we are not remembering it.
Very simple. We patients with chronic breathlessness are going to have an anatomy which is distorted. So they're very breathless. Their work of breathing is high and they're constantly breathless because of their underlying pathophysiology. What is the one thing that is hyperactive? It is the mind. The patient is going to therefore constantly be worried, anxious, panic. Oh God, I'm going to die. Oh God, if I go to the toilet, I'm going to collapse. So that is one phase. And because of the fact that he's breathless and he's anxious, he refuses to budge. He said, no, if I do this, my oxygen will fall. If I go to the loo, I will. Therefore, he becomes more and more. What is the word I told you? Deconditioned. He will become more and more deconditioned. So when he becomes more and more deconditioned, he will walk even less and less. So he's caught in this vicious cycle, which palliative care is aimed to break. The beauty of palliative care and its team, where the pulmonologist looks after the breathing, the psychologist looks after the thinking, physio looks after the functioning, and the social worker, volunteers, palliative care physician, nurses look after this whole thing. So our patients, if you can all do this little exercise, if you take a deep breath in and breathe half, take another breath from there and breathe half out. Our patients are in that situation 24/7, 365 days a year. Because if you've not experienced breathlessness, you will never know how a patient feels. And also, we all experienced during COVID how it was to be stuck in one room. Our patients are stuck in one room because they don't have a choice. They can't do anything else. They die a social death even before a physical one. They can't go out. They can't be independent to go to the toilet. They can't pick up the phone. They can't go and meet their friends. Their friends are all of the same age. So imagine this whole vicious cycle that they are caught in, which we want to break with palliative care. So all of you therefore know the definition of chronic breathlessness: a patient who is on under optimum treatment for his medical condition, which is bronchodilators, steroids, nebulizers, all of that, and continues to be breathless and affects his psychosocial health, his whole quality of life. That is when we determine these patients to have called as chronic breathlessness syndrome. So this is extremely under-identified. And because it is not recognized, very few patients get treated for it. Because this is COPD, interstitial lung, you have to be breathless. That's not the point. At least we need to do something to make him feel comfortable. Yes, we cannot revert the COPD. Yes, we cannot reverse the ILD, but we can have, and there are enough things to do to make him feel more comfortable so he leads a decent quality of life. Because if you see studies, physical deterioration in health is directly proportional to the mental deterioration of the patient. It is directly proportional. As and more the patient becomes less and less active, more and more dependent, he's more and more dukhi. And we completely ignore the coping strategies of these patients. We never ask the patient, how are you coping? What is it that you do in the whole day? How do you pass your time? Are you low in mood? What have you stopped doing because of your breathlessness? Or it could be small things like, talking to friends on the phone, or maybe gardening, tending to 3-4 pots, playing with your grandchild, meeting your friends downstairs for half an hour. All this is very, very important for our mental well-being and also quality of life. Man is a social animal, and we need to be surrounded by people and be able to do things on our own. So very, very important to see this, that mental health is as important and directly related to how much our patients are able to do. Also, there have been studies that has published how in interstitial lung disease, vis-a-vis cancer, the distressing symptoms is almost the same, if not more. So you need to realize that our patients ILD suffer probably more than cancer. And cancer does end up getting a lot of empathy and attention and palliative care intervention compared to those patients with interstitial lung. Also, the way our people with ILD die. Non-cancer conditions end up going more to ICU. Non-cancer conditions end up getting more CPR. Non-cancer conditions do not get treatment assessed for pain, for distressing breathlessness. So the whole concept of being treated like an individual, talking to these patients at end of life with, how very different how cancer patients are treated and how interstitial lung disease, but their needs are also the same. End of life, it really doesn't make whether you're going to die of cancer or ILD or COPD. They all need that same tender, loving care, attention, compassion, empathy. But it's clear that patients with ILD get way less than that with lung cancer. So how do you manage this? Again, you people are all trained palliative care physicians. I don't have to say it. Please try and use the battery operated fan as much as possible. It really does work. So besides the positioning, the breathing exercise, relaxation, distraction, etc., please do use the battery operated fan. It really does work. It really helps the patient relieve the breathlessness. And of course, the pharmacological assessment. Here, one word of caution about oxygen. Oxygen is also a drug. One should use oxygen when? Can anybody give me the indication? Anybody?
When saturation become less than 86%.
So 88. Below 88 is when we should use oxygen. All breathless patients don't get relieved by giving oxygen. If your patient is breathless, you try lots of the non-pharmacological, check the oxygen saturation. If below 88, only then use oxygen. Excessive use or abuse of oxygen also leads to oxygen-free radical damage by the nascent free radical. So you should use oxygen very sensibly and do not overuse it. Second word of caution about oxygen in COPD patients, if you make the oxygen cylinder 1, 2, 3, 4, 5 liters, that can result in type 2 respiratory failure. So you will be responsible to convert a type 1 to type 2 because the oxygen makes the brain says, I don't have to send respiratory signals to the lung. I can relax, the oxygen is there. Therefore, the lung starts breathing less and less and carbon dioxide expiration becomes less. And then there's the carbon dioxide buildup. So patients with COPD, please do not yank up the oxygen cylinder because the patient is breathless. Please keep it at 1 or 2 liters. Use other things like NIV for addressing breathlessness. Any questions on this?
Ma'am, how to screen for chronic breathlessness syndrome?
Okay, I will come to that. Okay, it is a very important question. So you have a patient who has been diagnosed COPD, who has been diagnosed interstitial lung disease, and still when breathlessness is at the top, and you can see that his activities, you can see he's dependent, you can see he's breathless at rest or even minimal exertion, changing position, sitting, standing, and then you can ask him questions of how it's affected his life, his mental health, and that is when so all patients who have been diagnosed with a chronic lung disease, as they follow up over the years, you know exactly how much they used to do and how much they're doing now. And if they're breathless at rest, those are the people who you should be discussing about psychology, physiotherapy, and then after detailed evaluation, start with morphine. Is that clear?
Yeah, thank you.
At rest, affecting psychosocial, affecting quality of life. And clearly, if you have been following up the patient regularly, or if the pulmonologist referring to you as, you know, earlier you could do this and now you're not even able to do this, that's when you start investigating and looking for chronic breathlessness syndrome. Okay. So therefore, with interstitial lung disease, the multiple approach with palliative care is actually, you need to address the symptoms because the breathlessness and the cough can be extremely distressing. It is very important to start the antifibrotics because it is hoped to delay the progress of the fibrosis. You need to have a good palliative care team because it affects the counseling of the patient, the physiotherapy, etc. Caregivers need to be supported and also taught what to do in an emergency, and very, very important to decide goals of care at end of life. So once you decide all that, most of my patients, the GP is trained, the caregiver is trained, there's a palliative care team going home. Most of the times I just get a message saying patient is not well. The GP has come home, has addressed the issues, and then I get a call or a message saying that the patient is no more. There is no casualty drama, coming to casualty, getting to ICU, then there is no hangama. Most important thing is you actually go through all these discussions with the patient and the family, and therefore we need early referrals. It's not the norm across the country, unfortunately so, but that's how we need to be, because in a chronic progressive illness, it is foolish not to tell the patients and not to foresee and foretell the disease trajectory. We wait for emergencies to happen, which is wrong. It should not be like that. Any thoughts, any questions? There's something on the chat, and this is a self-explanatory pulmonology for dummies. Never had it so good. Arre? No, not dummies. I am also learning along. So thank you for that. So in IPF, therefore, this is the dream interdisciplinary care we would like for our patients, where the patient and the family is in the center. You have pulmonologists, you have palliative care physicians, you have the palliative care team, you have people who can go to their house, respiratory nurses who can go to their house, and they need oxygen concentrator, they need BiPAP, all that, and also the pharmacist who actually helps them in supplying medicines, especially like morphine. It has to be an early integrated approach so that patients and families have the time to process and analyze. This is a dream which we hope to fulfill by actually talking to people like you interested in palliative care and wanting to take this forward. So another very important thing, which the reference is there on the slide. It's a beautiful article, and if you read that, you will cover everything on interstitial lung disease. And it's very nice algorithm because, you know, pulmonologists have this fear of sending the patient to palliative care. They feel they're losing the patient or they're giving up hope. And therefore, this algorithm really helps. And it is a little busy slide, but I'm going to share my slides with you all, and you all can read it very easily. And it's very, very easy to understand that it is a need-based referral and also depends on the certain clinical parameters like loss of quality of life, if the patient is depressed, if the patient has more, you know, emotional needs, when and how to refer these patients to palliative care. It's a good algorithm to follow in interstitial lung disease, which has a fibrosing or a rapidly progressive, which we call as idiopathic pulmonary fibrosis or IPF, which is the reason why we lost a lot of patients in COVID, because we don't know what hit them and their lungs really went into rapid fibrosis. Okay. So our goal in ILD as palliative care physicians is really to improve communications between patient and the pulmonologist and coordinate what we can do, which is the best interest of the patient, discussions against, and importantly, especially around end of life care, and so that we prevent futile, unnecessary medical interventions. And there has to be constant dialogue, communication, because patients tend to keep changing their mind. They shop around, they read of new things. Now the newest kid on the block is lung transplant for interstitial lung disease, which has picked up in the country. Not great results. Organ donation is still not very good. And the post-op is 50% success. And patients get a lease of life for 5 to 10 years. Not more than that. Not like a solid organ, like kidney, bone marrow, etc., where patients can live a decent quantity of life also. It's not yet with lung transplant. In India, it can cost up to 1 crore in private hospitals with admission, surgery, post-op, the post-op care, etc. So it is steep. It is not something that everybody can afford to do. So this is this thing for holistic care of ILD, which is A, B, C, D, E. And it's again from the same paper. I've shared that and I will share the slides. I don't think I should go into the details, but it's self-explanatory. And, you know, once you read the article, you will benefit from it. Before I step on to COPD, any questions, any thoughts, etc., please let me know, and then we can shift to COPD. Everybody's turned to silence or everybody's hungry?
Ma'am, how common is ILD, ma'am, in our routine clinical practice for
So let me put it in
non-pulmonologists?
perspective, you know, when I joined MD in 1992, I'm very old. I used to see interstitial lung disease, which is connective tissue related. So rheumatoid arthritis, systemic sclerosis, sarcoidosis, etc. And we used to celebrate those diagnoses. It used to be really like once in 4 months, once in 5 months. Progressively, now we almost have 1 interstitial lung disease per clinic. And I get referrals because I work with a very pulmonologist who's very pro-palliative. I see mainly 80% of my practice is interstitial lung disease. And the worst part is the age group is from 30 to 80. I have recently lost a 32-year-old ILD patient. It's very heartbreaking. It's a very cruel disease. So it is common, whether it is pigeons, whether it is the pollution, whether it is smoking, we really don't know why, but the incidence is definitely on the rise. And hypersensitive pneumonitis is very, very common in India. Having said that, idiopathic is also seen very, very commonly. Most of
And
my
what is
palliative
What
care.
is that hypersensitive? What is that, ma'am?
Yeah, hypersensitivity pneumonitis is allergic pneumonia. When you have hypersensitivity to pigeon dust or a fungal mold in your house or ventilate air condition which are not cleaned regularly. So that, people have the habit of feeding pigeons and staying amongst pigeons. So when you develop a hypersensitivity reaction or an allergic pneumonia, it is not infective, it is allergic. That antigen leads to severe inflammatory response in the lung, which leads to scarring and fibrosis.
It causes sudden death or like.
So there are
slow
different stages. It's acute hypersensitivity followed by chronic. Some people, when you arrest it in the acute with steroids, it doesn't progress to chronic. But chronic hypersensitive pneumonitis can last anything between 4 to 5 years. So it's not acute.
Okay.
It's not acute. It's not like how COVID deaths happened.
What are the initial presentation of
Usually,
hypersensitive pneumonitis?
so if you have to track back, now there could be an exposure to one of the antigens. Okay, like pigeon dust or excessive this thing. Typically, it is cough, shortness of breath, and type 1 respiratory failure. And CT will show typical characters of hypersensitive pneumonitis. Again, ILD CT patterns are the one which have made the lung biopsy less and less. Typical CT patterns, which is why I showed you that intralobular, interlobular. So depending on the distribution, the radiologists are able to make the diagnosis. So you need a good CT radiologist to pick it up. Any other questions?
Ma'am, it's only with the pigeon or any other bird?
No. It's usually, I mean, we have seen more in urban places with pigeon, but it could be even pesticides. It could be chemicals. It could be, really don't know. Basically, you develop a hypersensitivity to that particular antigen. Common causes are pigeon, but it's odd. 5 people stay in the same house and feed the pigeons. Only 1 person gets it. So we really don't know why.
Madam, in end stage ILDL, how do we manage palliatively? Is there any role for us?
Yeah. So I will, what I'm going to do is at the end, combine end of life for both COPD and ILD, because finally it is breathlessness, and I will talk to you about that. Is that okay? So
Yeah.
typically I will share with you what I do. We
Yeah.
educate the GP. We have already started the patient on low dose morphine. And when the patient continues to be very breathless or, its oxygen saturation is not maintained with 1 oxygen concentrator, 2 oxygen concentrator, and we know he's at end of life, we start a drip of morphine and midazolam, like a terminal breathlessness. And actually, we've done a lot of patients at home because they refuse to go to hospital. So we've done it with the help of a GP and a nurse at home, and the patient transitions in peace. But you need to be, I'll talk about the cautions and the things to do for good communication to start a palliative sedation at home.
Yeah, because most of the time, sometimes what happens, as you said, they accept the palliative care initially, but later on the children or somebody else, they have a difference of opinion. They, as a knee-jerk reaction, they want to take them to the hospital to put them into ventilator, and later on they regret that. But then again, that's like a knee-jerk reaction.
We actually, when we have that first meeting with the patient, almost always I follow up that meeting with that extended family meeting.
Yes.
With the GP. And then, so if you have an early referral, so one of the studies we did with the pulmonologist where I work, our average referral is 9 months.
Oh.
So I'm lucky that I work with the pulmonologist who sends the patient fairly early to me. So there's a rapport, there's a constant communication. We know the patient is declining. Then we again have a regroup, again have a session of, you remember, this is what the patient wanted. So what do you want to do? Are you feeling supported? If you don't feel supported, please come to the hospital, but insist on no ICU. So this conversation keeps happening till it's like almost like a rehearsal.
Yeah.
That they know exactly what to do. So our referral is almost 9 months before death.
That is what we lack, madam. We get it very late.
Oh, well, it is just one center in Mumbai. It is not everywhere. Second thing is almost 70% of our patients are on morphine. So they have led a decent quality of life before death. And the other interesting fact that we realized was patients' hospitalization, like I told you, hardly not even 90% died at home. And the reason why the other 10% came was also other reasons like small house, too many people in the house. It's difficult to cope with somebody dying in the house, plus small children. It's all logistically very, so that's why they came to the ward, but never ICU. So the point what I'm trying to make is, I think early intervention, good communication. Nobody wants to suffer unnecessarily, right? Nobody budgets suffering. And if you portray all these things about futility, what are we going to do in a interstitial lung disease by putting them on a ventilator? They think, but they need time to think. It cannot be outside the ICU. So that is the point. But yes, patients do change their mind, and patients have the right to change their mind. Their life, their body. So, and I'm sure everybody wants to hold on to dear life.
Yes.
So
Thank you.
can I move on to COPD?
Yes.
So this is a very interesting line from this article that stuck to me, and what we need to realize again is the fact that COPD symptoms could be worse than non-small cell lung cancer and heart failure, and unfortunately gets least referral compared to the two. And that's really very sad because our patients suffer for a long period of life. So when you have to describe COPD, where would the anatomy be affected in the lung? COPD
Small
is a
airways. Small airways.
Airways.
airway disease. It's not small airways. It is eventually it affects the large and the small. What is the exact problem of COPD? The elasticity of the lung is lost, because essential is of course the smoking, but of course also domestic pollution. That also contributes, occupational hazards, etc. So the elasticity of the lung is lost. Therefore, the lung doesn't recoil. Typically, therefore, there is hyperinflation. Air goes in, but air doesn't come out. So air sits, the residual volume keeps increasing. That's why what do you see on the X-ray? Hyperinflated chest, low flat diaphragms, correct? Chronic obstructive pulmonary disease. And the obstruction is to expiration. The obstruction is not to inspiration. So remember that in the flow volume loop, inspiration remains normal. It is the expiratory graph that is scooped out. Okay, because obstruction is in the expiration, and the patient expires less and less of air after each breath. Therefore, there is hyperinflation and the air is all sitting inside. So as the patient breathes out less and less, amount of breath in the next volume of air in the next breath is less. Correct? Because lung has a fixed capacity. So if he's breathing in, say 400 ml every tidal volume, he's only breathing out 150 ml. The rest of the 250 is inside. Next breath will be obviously less than 400 ml. So it becomes less and less and less, and that's why they are breathless, because they're constantly in hunger of air. Got it? Okay. So COPD, yeah. So when now again, this is the reason I'm jumping straight to this, is very often patients with advanced COPD get exacerbation, get infection, etc., and they get admitted to ICU. These statistics we should know, because when we talk of survival, we talk of patient has gone alive from ICU. That means he survived. But what happens to them after they go home? Majority, close to 40% are dead in 6 months. And in 3 years to 5 years, almost 70 to 75% are dead. That means what are we doing? We are only prolonging poor quality life. We are not able to change their disease pattern. We are just making them more and more miserable, more and more dependent, and it is equal to torture to prolong the poor quality life. So we feel as ICU pulmonologists, we have saved the patient and we have sent him home. But what is the patient going to do? Sometimes when we read research articles, we read this drug improves the PFT by 50 ml. Does that translate into quality of life of our patients? Does that translate into decent living with dignity and respect to our patients? That is what we need to do. Survival does not mean being alive. It has to be living well also. And our research modalities never include that as one of the aspects for research of quality of life, of improvement of our patients. So therefore, when to involve is a big, big thing for pulmonologists. So the surprise question should be, if this patient is sitting in front of you, will I be surprised if he is to die in the next 1 year? If the answer to this question is no, it is time for palliative care. And therefore, there are some indicators for this kind of questions to ask also in the first place. Specific for COPD, age, comorbidities, recurrent hospital admissions, severe breathlessness, grade 4-5 MMRC, on 24/7 oxygen, deteriorating lung function, and patient requiring 1 ICU admission. So if patient satisfies any of these two, start thinking the probability of him living up to next Diwali is going to be less. If it is less, involve the palliative care team. It also helps in transitioning the care of the human being. It's not like pulmonologist said, now I've done my job, now go to palliative care. It has to be transition because you have been his doctor for 10 years. Imagine if your doctor of 10 years says, I have done my bit, now go to this other woman. It should be a smooth transition. It should be continuum care for the patient. And therefore, it's very, very important to think of this surprise question and refer to the palliative care physician. So if you see the step ladder management of COPD, right from the time of his worsening breathlessness, you start obviously with inhalers, which is your muscarinic inhalers, short-acting, long-acting beta-2 inhalers, physiotherapy, your oral bronchodilators, oxygen in LTOT. But as you go, you have to start doing non-pharmacological interventions and then into opioids, along with all the disease-modifying agents. So typically, this is how the step ladder of patients with COPD with gold standard 1 to gold standard 5. You know that that is the criteria used to diagnose the severity of COPD. This is the question again on oxygen, that all patients of breathless are not hypoxemic. So you need to realize that hypoxia and breathless is not correlated. Patients who are breathless can be normal oxygen also. Oxygen doesn't change the dyspnea. You need to realize when you put the oxygen, yes, patients feel better, but oral morphine and hydromorphine, which is used in the West, definitely increases the sensation of breathlessness. The sensation of breathlessness is not reduced and not directly proportional to the oxygen. Okay, so please remember this thing. So when you think of a stepwise management, please think of your non-pharmacological, then start with SOS opioids in patients with advanced COPD, then long-term opioids, and then end of life is what I told you about palliative sedation. And this is just to show you a intervention which is done by palliative care people for patients with breathlessness called breathlessness support service. If you see the graph, the red is patients who had the breathlessness support service. The blue is without. So patients not only lived longer, but they also lived better with palliative care. So it's very important that a person is more relieved. Yes, the end of palliative care is death. We cannot change the outcome, but we make a difference to the patient's lives by touching his holistic approach. Talk of breathlessness, talk of how it impacts his life, his family, his social status, his psychological status, and therefore intervention really, really helps. Any thoughts, any questions, anything at all, just to break the monotony of listening to myself? Yes? Or anybody wants to share? Has anybody used opioids in advanced chronic lung diseases?
Hello, Didi.
Ma'am, this experience I have shared in one of the earlier classes also. One of the patient with non-small cell lung carcinoma, I guess, he was in terminal breathlessness and all, and I prescribed a morphine for him after 1.5 mg morphine. After 6 hours, he vomited, aspirated, and he died. So that day there was much panic. There was a class going on, and I shared that experience with in the class with others also. The pulmonologist was very
what is the learning from this? Very, very brave of you to share this. The learning from this is morphine the first time should always be given with perinorm. Because
That
morphine,
patient was on NIV also, ma'am.
no, but when you prescribe, first 3-4 days for the morphine to get used to the body and for the body to get used to the morphine, perinorm is good to give. So you can give injectable, you can give oral, and then administer the morphine. And we give really baby doses. So I don't think you should be responsible for the vomiting or anything, but this is just a caution. I have had such good experiences with morphine and COPD that patients who have come wheelchair to the clinic subsequently, I've had patients who have had the time to dress up nicely, shave, comb, and come walking. So it has made a difference to even how they look, even if their underlying COPD is the same. I have had patients, my interstitial lung disease patients on morphine who come with lipstick and put kajal. They take that effort and it makes a big difference to them. Imagine young 40-year-olds, coming back to the OPD looking pretty and walking. It's such a big deal. For them, it's really like achieving going to the moon or going to Everest.
Yeah.
Or there are patients who say, I've been able to sit and eat meals with my friends, or I can go to the toilet on my own. I pick up my own phone. I open the door of the house. It is a victory for them and it really makes a difference. And this is what this slide also shows. It's about 91 participants and it was done like how you do the pain scale, like a visual analog scale. And this paper actually says how there was a 9mm improvement. So the point here is how it translates to your patient's quality of life. That is very important because if you say, I have done this, I have done that, but my patient was able to go to the bathroom on his own is victory. My patient was able to comb his own hair, dress himself, bathe on his own. These are our small goals because we cannot go in and change how the patient lung functions. That's something beyond us. Sairu Philip has asked, is quality of life with COPD in the community a research priority? It should be, and I think there is something going on in the community as we speak. So we will get to know of the results soon. There's also a lady called Dr. Bharti, whom we heard in the IAPCon this year, who has actually gone and interviewed patients admitted with COPD in hospitals and found out how miserable they are in hospitals. So we feel we are doing a great job by admitting COPD patients, but they don't want to be there and not much difference happens to them. So the joke in the palliative care world is corporate hospitals where the rich don't come out and the poor don't go in. Because once you get one patient, you basically do everything for that patient. So, it's sad, but it is the truth because that's revenue generation model of the private hospitals.
Ma'am, when exactly, what is the exact time to start morphine in COPD or in ILD
Same.
patients?
So when you diagnose patients to be chronically breathless, depressed, unable to sleep, unable to do daily activities, breathless at rest, you can start trial with SOS. When you're very
Chronic,
sorry?
chronic breathless means, ma'am? Breathlessness for how?
Breathlessness
For
all the
24/7.
time. For example, they say, I go to the bathroom and come back totally out of breath. Okay. So you say next time before you go, 15 minutes before you go for a bath or try 2.5 milligrams of morphine. See how you feel. And then they'll report to you. If they feel fine, you can start twice a day. Then make it thrice a day.
IV.
No, oral. There is no IV business. This is all home management. And we rarely give IV. If at all we have to give parenteral, it is during end of life, or it is when patients can't swallow, or if the patient doesn't have a peg in MND, we give subcutaneous. There is no IV business. And
can continuous subcutaneous injection also be helpful?
Yeah.
Or
We give
intermittent
end of life. Yeah. So we give 2.5 morning, evening, then we give 3 times a day, then 4 times a day. Maximum, we give 20 milligrams to 30 milligrams is the maximum dose for breathlessness, morphine dose. Unlike pain, in breathlessness, there is a ceiling dose for morphine. Because beyond that, you're suppressing the respiratory center, which we don't want. Intent is comfort. Intent is not end life. So if your patient doesn't feel well after the first, up 10 to 15 milligram morphine, constantly you should try and explore. Is there something else? Are you anxious? Are you worried? Counselor, is there some problem at home? Are you being looked after properly? Go back to the caregiver, check out the situation. Because very often patients start feeling better with 10, 50. So I have just had a patient of mine who has been my patient for about 7 years and on morphine for the past 4 years. Today he's got admitted with type 2 respiratory failure, but with clear goals of care, of maximum ward care, no intubation, no ICU, only comfort care. Because he stays alone with his 80-year-old wife, and 80 and 83 obviously cannot cope in the house. So they've come to the hospital, but all these things have been discussed. And he's been on morphine for the past 4 years, good quality life. I mean, able to do his own, look after, self-care, talk on the phone, etc. So, it's important to assess for chronic breathlessness. Start always with SOS dose. See if the patient improves. Start small dose. The mantra in palliative care being start low, go slow. Start bare minimum dose, slowly keep increasing, explore all the other options, and then prove it to the, patient only will say it is making a big difference for him.
And when to stop?
So we don't stop unless the patient hates the constipation, because we always give laxatives, but still some patients get very irritated with the constipation. So you should not stop it. If the patient is responding to it, why to stop it? Anyway, this patient is in a state where he's in a chronic advanced lung. If anything makes him feel better, let it be. Like how we say diabetics at the end of life, eat sugar. How much time is there to live? Obviously they will not have buckets of sugar, but it's okay. One of ice cream, one of mithai, quality of life. No, finally, that is what matters.
I had some questions regarding TB, ma'am.
Yeah.
This TB diagnosis, is it many times delaying cancer diagnosis in ma'am? Few patients I have seen, they'll be treated for TB and sent, and they miss. So many patients present late with
the problem there is that everybody diagnoses TB with an X-ray when TB is a microbiological diagnosis. So when you have some patients who come with symptoms suggestive of tuberculosis, you can't stop at imaging. Even radiologists have a very bad idea of reporting, saying cavitatory lesions suggestive of COX. How can you see COX on an X-ray? You have to see acid-fast bacilli. Radiologists can give differential diagnosis. They cannot give the diagnosis. The minute somebody gives that diagnosis, the doctor, and unfortunately, TB is treated by everybody. GP also, chest physician also, non-MBBS also, everybody treats TB. And that is also the reason why the diagnosis gets delayed. If your sputum is negative, then you do a bronchoscopy. You go in and you remove the muck from there, correct? And you send for, once you have gone in and removed everything, you send for AFB, you send for gram stain, and you send for malignant cells. So the investigation, so the minute you feel that an X-ray is suggestive of TB, sputum is negative, send to the specialist, because the bronchoscopy can be done.
And ma'am, do you notice that there is a big taboo in telling that they don't, it is a notifiable disease, TB is a notifiable disease, but people don't, are not willing to get notified?
Unfortunately, HIV, TB, these are all, they are diseases with stigma. Even COVID was. So as a nature and a society and culturally, we have all this. All of us in this country have got the primary complex, the Goens complex of TB, because it is a country with high endemicity. Correct? When as adults we get tuberculosis, it is because of endogenous reactivation. It is not because of exogenous infection. So I have worked in a TB ward for 15 years. I have not got TB because I worked with MDR, XDR. Those days we used to not even wear masks. TB is a cell-mediated immunity disease. So if you have had good immunity, you will fight the illness. But if you are immunosuppressed, either HIV or you're undergoing cancer treatment or you've had immunosuppressant, then you catch TB like a cold. Otherwise, bulk of the disease that TB that India has is endogenous reactivation. It is there in everybody's lungs, the Goens complex. When you grow old, When you get diabetes, when part of your stomach is removed, when some cancer treatment happens, that endogenous TB puts his face. So if you understand the scientific logic of TB, there shouldn't be stigma.
COPD and smoking will increase chances of TB, ma'am?
No.
Okay.
Smoking will increase chance of cancer.
Okay.
Having said that, when you talk of MDR, XDR, and TDR TB, multi-drug resistant, extremely drug resistant, totally, it is a largely physician-made problem also. Because when we prescribe TB medications, we do not educate patients the importance of taking all 4 drugs for the first 2 months, followed by the next 4 months. It is important to tell them that 6 months treatment is necessary. Patients start feeling better, they stop the treatment. In this group, tell me how many of you have completed the course of amoxicillin 500 milligram 3 times a day? None of you must have.
Yeah.
How do you expect an illiterate, uneducated person to take isoniazid, rifampicin, ethambutol, pyrazinamide day after day for 6 months? Unless you have motivated him. And have you seen a TB prescription? It is HREZ MVBC pyridoxine calcium. So very often patients take MVBC pyridoxine calcium and think he's taking TB treatment. Have we told him first 4 is TB, next 3 supplements? Have we told him rifampicin will cause red urine? If any of you have taken rifampicin in your life, you will be scared to go to the toilet the next day. Because the bowl is fully red. You will immediately stop it if you don't know is a drug. So education, communication, man-made problem is TB, drug-resistant TB. Because patients have stopped it, then patient have gone to another doctor. Another doctor has given his own combination dawai. And if you add raw spoiled mango to a bunch of good mangoes, everything is going to get spoiled. So you keep adding drugs to a failing regimen, you're making a mess of the whole patient's life and lung.
Because I've seen one patient, the attender did not want to take him home because he's TB and they don't want to take him home.
If you are positive TB, you are a community hazard, right? Especially if you're MDR or XDR TB. The point where we should really see a difference is the National Tuberculosis Control Program and compare that with the leprosy control program. Leprosy is a vertical program. Only dermatologists treat leprosy. That's why leprosy is better controlled. TB, everybody jabs into it because ortho also comes for bone, somebody else heart, pericardial, the cardiologist is treating TB, nephrologist is treating renal TB. There is no confirmation. None of them are trained to treat TB. They should be sending everything to the chest specialists because we are the ones who are trained to TB. That's why the current TB mess in the country is because everybody and anybody looks after tuberculosis.
Thank you.
Yeah. So I already mentioned this, that the non-cancer group gets less and less of palliative care. And I would like to mention a little bit of COVID. I hope we have seen the past of COVID, fingers crossed. But when it happened, what actually happened is what is important. So only 5% of patients were really critical. But of course, 5% of 1.3 billion is a lot of people. So which is why we saw what we saw in this country. And what actually happened was it was an alien virus. Lung did not know of its existence. So the intense inflammation, which resulted in ARDS, pulmonary fibrosis, viral interstitial pneumonia, which led to interstitial lung disease. So the patients who died because of the ARDS and subsequently because of the pulmonary fibrosis due to this alien virus. So we should know about it because God knows what more viruses we are going to see in the next future. Added on top of that was oxygen-related injury, ventilator-associated injury, and therefore it became worse in patients with, so the treatment itself contributed to the deterioration. And who were more affected? The ones with high load of virus, the ones who had relapse or reinfection, and of course, other issues like mentally deconditioned patient, elderly, comorbidities, etc. And this is supposed to be the pathogenesis of the fibrosis in COVID, where you had high levels of TGF, and high levels of angiotensin converting enzyme 2. And that released the microblast activation, and that released the lung fibrosis, along with ventilator associated lung injury, and along with hyperoxygen, all that contributing to the worsening of the lung. So this article is also interesting read, which is by Zarir, a colleague of mine in Hinduja. And what we have seen over the 3 years of COVID is 1/3 of the patients improve within 3 months of the fibrosis. 1/3 remain the same. So there are patients of mine of post-COVID now with fibrosis, frank interstitial lung disease, and with oxygen, etc. And the 1/3 have died because of rapidly progressive fibrosis, which somewhere happens between early 3 to 6 months of being diagnosed with COVID. So these are the features that we see, which I don't think is important for you to know, but the images is something that you need to know. And this is what is typically described as what you should know is ground glass opacity. So you know how the shower, the glass becomes after you take a hot shower? That's how the lung looks. You know, when after a hot shower, the mirror, the glass in your bathroom, it becomes ground glass opacity. That is what is described in COVID, and this is how it looks. So if you see, this is what we call as ground glass opacities. Can you see this? This hazy thing, this is the ground glass, this is acute. And that's why steroids help, because steroids are the most potent anti-inflammatory we have. But like any other part of the body, when there is active inflammation, it heals by scarring. And that is what led to the fibrosis. And that is what unfortunately led to all our patients suffering so much. 1 minute. Okay, so you know all what we did. All of us are now very well read about what we did with post-COVID and interstitial lung disease. The thing is the same as interstitial lung disease, where you need palliative care, oxygen, pulmonary rehab, morphine, vaccination against pneumonia and other viruses, and now lung transplant. So in Apollo Chennai, I think they have done 2 lung transplants for 2 young patients post-COVID, but the numbers are much higher in the US. And follow-up, of course, we do like any other interstitial lung disease patients, but COVID survivors, this is another interesting piece of information, where actually very few people who have survived and who are lived, most of them have resolved. So it's not that bad for a lot of people. Of course, it's awful for those people who died. And restrictive defects were found only in 25% of cases. And a lot of these patients are fairly well. There are a very small percentage of people who have post-COVID lung. They have a lot of post-COVID other issues like brain fog, fatigue, unable to focus, etc. But lung, again, 86 severely ill patients. This is one paper from Austria, where CT was first found abnormal in 88% at 6-week discharge, but that had dropped to 56. So honestly speaking, post-COVID fibrosis, those who survived the initial thing have improved, but those who didn't survive, of course, it's a sad story. Okay, so this is all not. And I think another important thing to leave with this group is that palliative care doesn't need a big setup. It can start from a OPD, casualty, ward, ICU. You should think of palliative care everywhere. Just because the patient is in ICU doesn't mean he goes in for everything. You need to know when to stop, when to withdraw, when to withhold, and when to have these difficult conversations. You could have a patient, say a 50-year-old who comes with subarachnoid hemorrhage. Absolutely fine 1 minute, not the next. You investigate subarachnoid hemorrhage. You should start talking of organ donation, because this man is brain dead. We should ventilate him like Kerala rules only if he is going to be a potential organ donor. In Kerala, if a brain dead person is not an organ donor, he is not offered ventilation, because it is futile medical intervention. So it's something to think about, because organ donation also is not that much in the country, and it's very, very sad to see young viable organs being burnt or being buried when some people can lead a decent life. Now coming to NIV, please tell me if I'm too tiring or monotonous, or you want to have a break. Everybody wants to go for a walk and come back. Surfactants don't help in post-COVID because it is scarring. Scarring doesn't make a difference at all. Everybody wants to go for a walk and grab a glass of water or something? No. So NIV, somebody was asking about NIV, I think in the chat box before. So it is something that came when I was just finishing my MD. So I basically learned it on the go. It is a great tool and a great step for patients with advanced lung diseases, one step away from ICU. And if the patient doesn't want to go to ICU at all, and we also have managed to keep patients at home on NIV. So it can be used in both acute and chronic. It is non-invasive ventilation. And basically the funda being it is given positive airway pressure, which is that the machine delivers a pneumatic splint. So if there are largely two kinds of NIV, which is continuous positive airway pressure, where you give a continuous pneumatic splint to keep your airways open and patent, like what you use to treat in obstructive sleep apnea. And then there's a bi-level positive airway pressure, which is inspiration and expiration is different. It facilitates the expiration of carbon dioxide, typically used in type 2 respiratory failure or in congestive cardiac failure, where there is a lot of pulmonary edema. It squeezes the lung to empty the fluid from the alveoli. Okay, so pneumatic splint, which improves the transmural pressure, it reduces airway edema, it also improves the airway tone so that there is a stimulation of the mechanoreceptors, and it also increases the lung capacity. So it's been a great discovery, but we really need to use it judiciously because it can be extremely uncomfortable for the patient. So you should try NIV, but don't force NIV to the patients because it is a mask tightly fitted. It cannot have an air leak. Patient can't talk. There are abrasions. There's a barrier. So it's not easy, but those who get used to it, they really do very well with home NIVs also with time to time review. So CPAP, BiPAP and AutoPAP. AutoPAP is again something where patients need different pressures that the machine itself titrates it according to the needs of the patient and therefore delivers the positive airway pressure. Okay. So clinical parameters to start is at least two of these, which is high respiratory rate, more than 25, respiratory acidosis in an alert patient. You can't use NIV in an unconscious patient. So respiratory acidosis according to the ABG, moderate to severe dyspnea with accessory muscles of respiration. And when the patient has paradoxical breathing, which means during inspiration, his abdomen is going in and expiration abdomen is, inspiration abdomen is going in and expiration abdomen is going out. So actually when you and me inspire, our abdomen should go,
Out.
So when you do yoga, that's what they tell you. Why does it go out? Because the diaphragm goes down and correct. And when you breathe out, your abdomen should go in. But paradoxal breathing is exactly the opposite. And when that happens with type 2 respiratory failure or respiratory acidosis in an alert patient, you can use NIV. So absolute contraindication is respiratory or cardio arrest, which means the patient is really not there with you or unconscious. Cardiac MIs, those are the absolute contraindication. And also locally, if there is an anatomical issue, facial head trauma, then there's no point using NIV. Okay. Relative contraindications, of course, copious secretions, extreme obesity, but these are relative. You can encourage the patients to use. So any other questions on NIV? I wanted to keep it brief because I knew there would be more questions and I didn't want to keep doing this screen sharing business. Any more questions on NIV or thoughts on how you have used NIV, your problems with NIV?
How long can we use it in COPD in a homebound patient?
So we usually tell patients to use it during sleep. So both daytime sleep and nighttime sleep, because it helps as an accessory muscle. It helps the CO2 to be retained. It helps the patients get proper oxygen so that they can sleep well in the REM phase of sleep. So we usually tell them at least 4 to 5 hours during the night.
That's what we usually do.
Sorry?
That's what we usually do.
Yeah, where we use a little more prolonged is in neuromuscular conditions, like junctions, like motor neuron, where there is no muscle activity. Their patients are there almost 24 hours. It can be quite distressing for the relatives because they have to feed. And if the patient wants to, if the patient is able to talk, then that is not possible. But because sometimes patients with bulbar MND, they get breathless even before they lose peak, you know.
Consciousness.
Yeah. And see, in MND, they're very alert all the time. It's the cognition doesn't have a problem. So the breathing is so labored that morphine and BiPAP is what works best for them. And they're on BiPAP almost 24/7. Another indication is the left ventricular failure, congestive cardiac failure. BiPAP works very well because it lets the oxygen come in, it squeezes the alveoli out. So cardiologists always try the BiPAP in an LVF. It is oxygen, Lasix, BiPAP.
Oh, BiPAP is good for end-stage left ventricular failure, isn't it?
Any LVF, initially you should give BiPAP by the time the Lasix and the oxygen start acting.
Thank you, sir, for saying that. That's very good. Thank you.
BiPAP really does a great job for cardiac.
We've not used it. I mean, even cardiologists in our place have not suggested that.
No, BiPAP works very well for CCF because again, it helps in because of the positive pressure and the bi-level pressure, it actually squeezes out the lung best.
Yes. Thank you.
Sorry? I thought somebody said something. Another important thing for this group is please don't forget other symptoms that patients with chronic respiratory disease face. Insomnia, fatigue, loss of appetite, weight loss. We as pulmonologists hate it when the patient says, I am tired all the time, I cannot eat, because we don't have solutions for that. But in palliative care, at least listen to them. There's lots we can do, go through the diet, refer to the nutritionist, acknowledge the distress. Because of the lack of oxygen, a lot of patients have a problem with digestion because obviously the brain prioritizes the breathing to the digestion. So less oxygen is going to the stomach. They feel full. So small, frequent diets, power pack the nutrition. They can't eat large volumes. So listen to this because it makes a huge difference. I know most pulmonologists get very hassled when the patient starts saying, I'm tired or I'm all the time fatigued. So it's very important to think of these symptoms because imagine the patient is awake all night, every night, 24/7. It's really distressing for the caregivers and the patient. So
what about depression in these patients, madam?
Very high. That's why we say it's very important to have the breathing, thinking, functioning model. You must include the counselor. You must have a psychiatrist or an antidepressant if the counselor feels so. So, which is what the beauty of palliative care teams, because they are all paramedics involved in the care of the patient. It's very, very high. It's very easy to be frustrated, angry, depressed when you're bedbound, housebound, unable to do anything. It completely strips your dignity. So these patients are surely depressed. So you must address that. Okay. And caregivers. If you have had, imagine the caregiver who's looking after a father of COPD for 15 years. The caregiver has no life. He's running to hospital, running to OPD, getting oxygen, cannot leave the house. His own life is in balancing act. So it has been researched and proved that they want to understand the mechanism of breathlessness, involve them in the non-pharmacological interventions, help them to teach the patient how to manage anxiety. Please don't ignore the caregiver. Please ask the caregiver, are you okay? Are you coping? Are you eating and sleeping? It's not easy to be a caregiver. It's a very invisible job. And in this country, it is thought it is our duty. A son has to look after the mother. A daughter has to look after the father. A wife has to look after the husband. But they also need a break and they also need to be addressed and asked whether they are coping okay. We really need to include this in our history taking when you see sometimes caregivers look more harassed and more haggard than the patient. And he cannot look after anybody, he or she is mentally, emotionally, or physically disturbed. And there's enough research to suggest that patients with chronic breathlessness, the caregivers also go through a harrowing time. They're forever scared that when is the next ICU admission? Or when am I rushing to the hospital? When am I calling the ambulance? So please look after your caregivers. And now coming to the terminal breathlessness, which most of our patients can experience. Extremely important to evaluate and select your patients. Involve a specialist palliative care, physician and team. Talk to patients and relatives about what it means because the patient will become unresponsive. Intent is comfort. Intent is not end of life. But like the doctrine of double effect, the bad effect is death. Prepare them for that. Idea is that the patient transitions in sleep and not like a fish out of water. That is the most horrible way to remember a loved one towards end of life. Like the famous saying by Dame Cicely Saunders, the manner in which a loved one dies is etched in the memories of those who live on. The bereavement period is much better if the patient has died in peace with no suffering. But you need to talk to patients, you need to talk to relatives, what it means. We give it subcutaneously. We also have given it at home. We get the syringe driver, 10 milligram morphine, 1 milligram, 10 milligram of midazolam over 24 hours. And always start low, go slow. We just give enough to alleviate symptom where the patient from 35 respiratory rate comes to 20 respiratory rate. Like he's as if he's sleeping. If the patient is agitated, we add haloperidol. And then we keep changing this every 24 hours. Usually the time we start, it doesn't exceed to more than 2 to 3 days, because that's why I said careful selection of patients. So other comorbidities, urine output is falling, or patient has an infection which they don't want to give antibiotics, patient is shallow breathing, patient is not able to maintain oxygen. That is when you start the that is when you start the palliative sedation. And the intent, please remember, is comfort. It has to be documented. You have to take the necessary signature after relevant conversation. So this is a slide that actually combines the whole thing. What it is, what is the clinical significance. It is not euthanasia. Very, very important. It is not that we give one full bolus of thing to intend to kill the patient. So please remember, this is very, very important. All this, I will send it to Pallium and they will share it with you.
Do we take an informed consent before we start it?
Yes, yes, of course, please. Very, very important. Because some families want the patient to keep talking till the end. That's not going to happen.
Yes.
And the reason it's not going to happen is really in the best interest of the patient. Because otherwise the patient will be completely like a fish out of water. And it's horrifying to see that change. And it's not that you start the drip and the patient falls asleep. The patient also takes some time to fall asleep, but at least the patient starts getting calmer and much more quieter. And then it's much easier for the relatives also to be around the patient. Otherwise, most relatives say, I don't want to see this. Or, this is horrible. What are you doing, doctor? It's not a very easy decision, but you need to talk about it much in advance because it can come. Because our patients with chronic lung diseases, unfortunately, not all of them go away like this. It's a lingering end, and that can be very, very difficult for patients and caregivers. And apologies, I have overshot my time, which is not nice. Now I have kept you away from dinner. Yes, so any question? I know it's tiring, but Pallium has my contact details, my email. Please feel free to write, ask queries, discuss patients. More than happy to do that.
Yeah, Dr. Vidya.
So, ma'am, how much it is valid to have the pigtail catheterization the patient with advanced disease in oncology?
Pleural effusion.
Yes, ma'am.
See, we then gauge by prognosis. So if the patient has got more than 4 weeks, Kornofsky scale, all those other scales which predicts the functional status, more than 50% on the bed, less than 50% on the bed. So if the patient has a decent prognosis, now we can put pigtail. If the patient is imminently dying, then you just do an aspiration and treat the symptoms with morphine or oxygen, etc. Why to keep poking the patient? It all depends on
and it depends on how much we aspirated the last time, like that. If we aspirated 350 ml in a week twice.
No. See, suppose the patient is like poor prognosis, you can aspirate up to 1 liter. Point is, you should not be the one to cause a re-expansion pulmonary edema. So you aspirate up to 300 to 400 liters because that will give the patient relief. Then leave it. then give the patient morphine. Now, don't keep poking a dying patient. I would really not recommend. Less, decrease the investigation, decrease the monitoring. If you're not going to actively intervene and change things, then why to monitor and register those numbers? Sometimes ignorance is bliss. Just let them be. And you know it's advanced cancer, you know it's metastatic cancer. As far comfort should be your gauging. And if you've made them comfortable, then why keep poking the patient? If the patient has a good prognosis, you should put in a pigtail so that it drains on its own. Any other questions or thought, but I'm sure all of you are now surely hypoglycemic.
Okay. So I think we can wind up the session for today. So Dr. Rajan talked about many things today, starting from respiratory failure to palliative sedation. So there are a lot of information which you need to digest from type 1 respiratory failure is lung failure to type 2 is pump failure. So thank you, Dr. Rajam, for this wonderful session, and that also in a very simple language for us to understand.
Thank you, Sunil. Thank you for this opportunity. And somebody's commented that it was a good pulmonology lecture, and I'm glad because I love my teacher who taught me, and she'll be glad that I learned well. But having said that, I've also teased upon certain things so that you think and come back to me for more questions. So, I mean, I didn't want to go into the depths of everything because it's not possible in 1.5 hours to teach what I learned in 3 years of MD. So come back. We can have more sessions, or maybe you can give a feedback to Pallium to break up the session so that it's easier for you to, comprehend and digest everything. I know I'm asking for more work, but I'm happy to teach. I enjoy teaching, so it's fun. I also end up learning. So thank you very much for this.
Thank you.
Good night. And Sunil, I have replied to your message late, but I've sent you a message.
Okay.
Thank you. Bye.
Thank you, Dr. Rajam. Actually, I have been troubling her from 5 p.m. today. Hope that you had time to grab your quick dinner, ma'am.
My bad, because I didn't realize both the sessions were on 17th. Because the emails came at different times, so I didn't realize it was the same day. Don't worry, I have finished dinner at 6:45, so no problem.
Thank you so
Thank
much.
you all, and really hope to meet you all in person sometime. I've met Sunil and I met Shri Priya this time, but not most of you. It's all just familiar. And of course, Jagruti I've met, but not most of you. So thank you again.
Thank you, ma'am. Thank you for joining in, and please do take sufficient rest and take good care of yourself.
Will do. And all of you too. Take care. Bye.
Bye-bye, ma'am. And just reminding that tomorrow also we'll be having a session. And the session would be from 7 to 9 p.m. as well. This is Sripriya, along with Dr. Rajam Iyer and Dr. Sunil Kumar, signing off from the Pallium India's desk. See you tomorrow till with another interesting topic and 2 eminent faculties joining in for the evening. Till then, everyone, take care. Bye-bye.